we make a start. So welcome everybody. I hope you can all hear me. I'd like to welcome you all to Professor Adam Rosenthal's Inaugural. I'm absolutely delighted that you're all here to share with our welcome sort of adoration of everything that he's achieved. I'm Anna David. I'm a consultant in obstetrics and maternal fetal medicine at UCL and UCLH, and I also run the Institute for Women's Health. And I've known Adam really for a very long time, I think. I think the secret of Adam is that he's really a very good obstetrician. He wouldn't want to tell you that, and he certainly wouldn't want to work on our labour ward and do our shifts at all. But if ever we have a shortage of obstetricians, Adam's your man. Because I do remember doing a couple of quite tricky forceps deliveries with him quite a few years ago, and he was absolutely brilliant. So I'm sure he's going to talk you through his history, how he got to where he is today. But I thought I'd just put in a few little points about him. So he trained at St Mary's, and in fact, we were just comparing notes because we also worked at Ealing Hospital many, many years ago. And then he went to Barts, where he worked with Ian Jacobs as a research fellow, and then came back and spent some time at UCLH, where I met him. And then he did a little bit of jiggery-pokery back and forth between Barts and UCLH, couldn't quite decide, and then ultimately decided on working at UCLH, where he's been a consultant in gynecology oncology. And he's really taken forward the whole clinic about prevention of ovarian cancer and also cervical cancer as well. So this has all been done while working as a full-time NHS consultant. And people say to me, you know, oh, isn't it really tricky to put people forward for promotion to professor at UCL? And I say, well, yes, it is quite tricky if you work as 100% academic at University College London, because you've got to justify everything you're doing. But for everybody that I've put forward for promotion at UCL, who is a full-time clinician, it's been a walk in the park, because people are so talented. They're essentially doing their academic work. They're having impact on patient care. They're changing clinical practice at the same time as doing their NHS work. And I won't sort of steal his thunder, but he's had huge impact in prevention of ovarian cancer and also cervical cancer. And he's also a fantastic clinician. So I get to see quite a few of his patients who've seen him and then come to me having had quite a lot of cervical surgery, and I try and help them get through their cases. So I know he's a brilliant, talented clinician. He's also a brilliant teacher as well, and also very good at bringing in grant income, publishing papers. He's been on Channel 4. He's been on, 5 News. He's an advocate for patients via his charitable work. So an ultimate good, all-round, brilliant person. So I'd like you to put your hands together to say congratulations, Professor Adam Rosenthal.
Oh, it's just a scary audience. I think pretty much all of you. Thank you very much for giving up a Friday evening. It is appreciated. Everyone has busy lives. Welcome also to those of you joining online, including some very eminent people whose names you can hopefully see there, and there are many others as well. 40 people registered for online, apparently. The boring bit first, you're meant to talk about your disclosures. This is my disclosure. But first, a word from our sponsors. As you can probably hear, this lecture is brought to you by, I have many people to thank, and I may forget to thank some of them, but I promise I won't do a Gwyneth for you. Now, our celebrations for this, this occasion actually started over a year ago, really. Because we had a consultant meal, and the provost gave me an award. But where is Joseph? He's here somewhere. This is actually one of our colleagues, Joseph Iskaros, pretending to be the provost and handing me an award. And those of you who are eagle-eyed and work in colposcopy will have spotted that this award was all in the best possible taste. So the first person I want to thank actually is one of our obstetricians, Raf, because at one of these consultant meals, Raf said to me, why hadn't I got a chair yet? And I said, well, I never really thought of applying, to be honest. And he said, no, go on, do it. And then I spoke to Anne and Anna, and they were both hugely supportive and really helped guide me through the process of applying. And there's an awful lot of paperwork involved, but they were really outstanding in supporting me with the process. So Anna's alluded to my my sort of career path, and I'm not going to go through every single one of these in detail, obviously, but suffice it to say that next year it'll actually be 40 years since I entered medical school, which is a pretty sobering thought. So I may be old, but I did get to see all of the best bands, and as many of you know, music is one of my main driving forces outside of my family, friends, and medicine. So our story starts over 50 years ago, and this is me. And actually, I was born at this hospital, just down the road on what's now the Macmillan Cancer Centre, but it was at one time the obstetric hospital on Huntley Street. And I was a pretty cheerful chappie, apparently. I have very fond memories of childhood, which isn't surprising, really, because my parents were really outstanding parents. Sadly, my dad, Tom's no longer with us, but my mum, Anne, is in the front row here. And this was them with me at, I think it might have been the BSc or possibly the MBBS graduation. And then me getting my PhD. And then with my brother Daniel on the photograph below, repaying the favor because my dad got a PhD, I think in his 70s, from the University of Cambridge, where he'd been an undergraduate on the basis of his published output in the field of various painters. And then to cap it all, my brother Daniel here gets a PhD along the same lines later. So we're a very PhD heavy family. But I was given an absolutely outstanding education as a child, and I went to this place near Swiss Cottage in London, the Hall School, which I have very fond memories of, except for the absolutely dreadful school uniform that I was forced to wear. And we all know that in the history of humankind, there's only been one person who's ever made this kind of uniform look good. And his name is Angus Young, the lead guitarist for AC/DC. And in case you're wondering, yes, I have seen them twice, and they were excellent. So from there, I then moved on to another school, and it's getting a bit repetitive here, but yes, there's a link again to UCL. This is University College School up in Hampstead, founded in 1830, and those of us that went there are called Old Gowers because originally the school was on Gower Street, just down the road from the university. So hands up if you recognize this. A few people, okay. So if you were a child growing up in the 1980s, you might have seen Grange Hill, and at the time, groundbreaking program. And you're all thinking, what the hell is Adam talking about here? So bottom right there, you can see one Pogo Patterson, that's his character anyway. And you can see him again. And then in the summer after my O-levels, you can see me next to him with an insane amount of hair because I was an extra in Grange Hill. Bet you didn't know that. As well as really hopeless attempts at acting, I also played the drums, and my excuse for the headband is it was the 1980s. And according to the school magazine, I look like Rambo, whatever. So I did do a little bit of acting, mainly, if I'm being honest, to try and meet girls, because we were an all-boys school. And this is the cast list from Oh, What a Lovely War. And Lisa Roberts, who you can see on the left of that list, is in the audience now and still a great friend of mine, a GP in North London. But those of you who are eagle-eyed might have spotted this name here. And you're thinking, why do I know that name? And maybe this is giving you a little bit more of a nudge. And how about this? Yep, I did act with Hollywood and star of big and little screen actress Olivia Williams. I've not seen her once since, probably because in the waltzing scene that I had to do with her, I trod all over her toes. So I knew, I think, from about the age of 13 or 14 that I wanted to do medicine. And we all know that if you want to do medicine, it's a good idea to go and get some experience on the wards to put it on your application form. And it turns out that the school, because of its links, sent me to this place, which you may recognize as the Cruciform building which is now part of the UCL campus, but was originally University College Hospital. And I was on the pediatric ward as a 16-year-old, I think, 15, 16-year-old, with two other kids from the school. Guy Lepsky's now an anaesthetist up at Sheffield. David Kaufman went into finance. 2 out of 3 ain't bad. So we moved on to medical school afterwards. And as already mentioned by Anna, I went to St Mary's. I went around I knew I wanted to stay in London. I went around all of the London medical schools to visit them. And basically, I thought the students at St Mary's seemed to be having the best time. And that's why I chose it. I was lucky enough to get in. And this dreadful mugshot is what I looked like back in 1986 when I entered medical school. And it just reminds me of one of my favorite films, The Usual Suspects. So medical school was fun. Glad to say I didn't take up smoking, but I did meet a lot of great people. And this was what we all looked like in 1988. Thanks to Evie Mensa, who's in the audience, furnishing me with this shot. And those of you who are really eagle-eyed will possibly spot 2 obstetricians and gynecologists in this group. One of them, Mark Denbo, who's up in Bristol as a people medicine consultant now, and Nick Wales, who's not far from here at Chelsea and Westminster. So this is me, clearly in total denial about my male pattern balding. And I'm next to here Neil Sabir, who those of you in the obstetric side will probably know, is actually the professor of pediatric pathology at Great Ormond Street Hospital. And Neil and I got to know each other because basically the medical school wasn't very adventurous in how it sorted out our firms. It did it alphabetically, and I was next to Neil in the alphabet. And I think that our relationship at the time was basically telling you the direction of my career, which is that I would find the brightest kid in the class and I would just hang on to their coattails. Neil is an absolute planet brain. And if I hadn't been on his firms in the final year, I'm sure I would have struggled in passing my medical finals. So big thanks for Neil for getting me through medical school, essentially. But it wasn't all about the work. Huge lifelong friendships were formed. And this is our medical school band, Dutch Courage, and Neil and Richard from the band are in the audience. And every so often we get together. And the last really memorable time was on my 50th birthday when we hired the Kinks room at Clissold Arms in Muswell Hill, so called because it's the venue that the Kinks allegedly played their first gig at. And there we are performing for my 50th, which was wonderful fun. So back to work. The medical school allowed me to take a BSc unusually in the 4th year. And perhaps there's some little hints here as to what I would end up doing, because there was a bit of research in this BSc, but also there was a module that I chose to do in fetal and neonatal physiology. Sorry, I'm not an obstetrician anymore, Anna. As Anna mentioned, some house jobs in Ealing. My memories of that, I did a lumps and bumps list completely unsupervised, which is pretty shocking when you think about it. Did an appendectomy, I'm glad to say that was supervised, but mainly survived a 1 in 3 and a 1 in 4 rota in surgery and medicine. It was a tough life, but a very enjoyable one. Then on to SHO jobs. Those of you that work in the field will know that these were some of the biggest names around at the time. Some of them are still around. And it was a real honor to work for them. And I learned huge amounts working for these bosses. The other important thing to notice is Hammersmith, because that's where I met my wife, Sue, who's here with our sons, Bruno and Arnie. Sue was an SHO in A&E. I was the gynae SHO. And she would call me down a lot to see patients. And I always said yes, because it was a chance to see Sue. So I first started research properly in my SHO years, and an audit project I was asked to do by the Labour Ward lead, Sarah Patterson-Brown, was to look at her anecdotal experience, which was that older mothers did worse in general in labour. And it turned out that no one had actually looked at it, at least not in a linear fashion. And these are the rates of deliveries by pre-labour caesarean, instrumental vaginal delivery, emergency caesarean, spontaneous labour, emergency caesarean and instrumental vaginal deliveries, fetal distress and failure to progress. And you can see that every single one of these indices gets worse with maternal age. And we hypothesized this was down to the aging uterus not being able to push babies out so much. I no idea if that's true or not. My obstetrics colleagues could hopefully elucidate that. So that was my only real foray into obstetric research until something which we'll close off the talk with pretty much more recently. So I now like to concentrate on what most of my consultant career has been about, which is preventing gynecological cancer. So gynae cancers are pretty bad news. Over 20,000 UK women per year get a gynae cancer, and there are over 7,500 deaths per year. But much of it is entirely preventable. The cervix is the easy one relatively, because we now have not only excellent screening, but also vaccination. And because 99.8% of cervical cancers are down to human papillomavirus, we could, in theory, prevent nearly all cervical cancers if everyone went for screening and if everyone got vaccinated. But let's not forget that 70% of vulval cancers are due to HPV as well. And I think there's a lot still to be done about destigmatizing the vulva and self-examination of vulval skin so that women consult early if they have abnormalities on their skin, because thereby you could also prevent an awful lot of vulval cancers. Then the other main area of my interest has been the inherited autosomal dominant causes of gynecological cancers. Autosomal dominant, pleased to remember everyone, that means it's passed down from men and women equally. And therefore, just because these genes tend to cause female cancers doesn't mean you can't have got them from your dad. And that's sadly a mistake that many clinicians have made over the years with sometimes dire consequences. So Lynch syndrome, which is probably around about 1 in 400 women in the general population, accounts for about 3% of endometrial cancers, and BRCA1 and BRCA2 and other genes, including Lynch syndrome genes, overall account for about 15% of ovarian cancers. And genetic testing, of course, is the way you find out people have these predispositions. And in fact, it's probably cost effective to screen the entire population for these genes. But I would ask rather, is population-wide testing something that society as a whole is quite ready for? And we can debate that till the cows come home. But the idea is you identify who carries these gene alterations, and you then, at the moment, sadly, the blunt instrument we have is to simply remove the organs of risk. Now, the other main cause is obesity, which is a bit of a bugbear of mine. 1 in 3 endometrial cancers are down to obesity, probably about 7% of ovarian cancers. And we are battling this at the moment using the levonorgestrel IUS or Mirena, a contraceptive device for treating patients with atypical endometrial hyperplasia, which is the precursor lesion for all obesity-generated endometrial cancers. And yes, we've got anti-obesity meds, we've got bariatric meds, but seriously, what we all know is that we need to sort out corporate greed and the politics of the fast food industry and highly processed foods in our supermarkets. I won't say anything more on that, but it does make my blood boil, because basically highly processed foods are the equivalent of the tobacco industry back in the 50s, 60s, and 70s. So back to some research now, and this was the first paper I published to do with this area. And again, it was another SHO audit project. I was working for Pat Souter at the time at Hammersmith, and we simply audited the pathologies found in women presenting with postcoital bleeding, and we found that there was really quite a high proportion of the precancerous lesions, CIN2 and CIN3. And those of you that practice colposcopy will understand this. This is logical, because if you have a patient with an advanced precancer and you're examining them frequently, the epithelium, the skin of the cervix, simply shears off as you're examining them. And this is because the cells lose their gap junctions the more dysplastic the epithelium. So it doesn't take much pressure for the skin to simply fall apart when you're examining it. And therefore, you can imagine that during intercourse, that skin would be easily damaged and bleed. And I was astounded to see when I started training in colposcopy in about 2006, I think it was, that the national guideline for how you should best practice colposcopy in the UK actually referenced this paper as one of the reasons as to why women with postcoital bleeding should be examined. So then, having worked out that I wanted to concentrate in gynae-oncology, it was time to think about doing a proper research job. And Pat Suter suggested I came to see Ian Jacobs, who at the time wasn't a professor, wasn't the extraordinary character he's gone on to be since then. He was plain old Mr. Ian Jacobs, newly appointed senior lecturer in gynae-oncology at BARCS. And I had 3 fantastic years working under Ian, doing my PhD thesis in the east wing of BARCS, which you can see is very picturesque. We were down in the basement, but we still got to see the fountain every time we went there. And also just on the other side of the square at BARCS is the extraordinary Great Hall with the mural, the Hogarth Memorial, the William Hogarth mural, which we had the great pleasure of walking past every time we went up to our annual meal in the Great Hall. And the time at BARCS was not just down to Ian, it was also down to my colleagues. And if you look at the other research fellows that came through the unit at the time, you'll understand why I had such an extraordinary experience. So shortly after I joined, we were joined by Usha, who of course we all now know is the exceptional professor of gynaecological cancer at UCL. Nicola, who I'm glad to see is in the audience, Nicola MacDonald, wouldn't tell you, but she won the gold medal at MRCOG. She is, of course, one of our gynae-oncologists and now heads up the whole of the regional network alliance for gynae-oncology. Also, I'm glad to say here in the audience, all the way from Utrecht, Ronald Zwemmer, professor of gynaecological oncology there. Ronald and I became great friends during our time at BARCS. And also, not here today, but Philippe van Trappen, who heads up one of the major centres in Belgium. So how could I fail to have had a stimulating and good time working alongside these folk here? I won't go into huge detail about what I got into in the PhD. It's pretty esoteric, but just suffice it to say that despite using what at the time was state of the art, but would now be considered laughably basic molecular biology techniques, we did manage to find some of the epidemiological observations around vulval cancer, such as the fact that it's not all due to HPV married up with the molecular events. And something that I personally found intellectually stimulating was discovering a new phenomenon, at least in this type of cancer, which was something called epithelial spread, where the precancerous cells have the ability to spread through the normal skin before they invade down through the basement membrane to become a cancer. And we did manage to publish all of this work, I'm glad to say. One of the appendixes actually ended up as a Lancet publication, believe it or not. But I think I put this up really more for the fun of noting that despite the Lancet being, you'd think, a pretty well-off journal, quite clearly they've employed someone a bit lackadaisical with their scanning, because look at how dreadfully it says Lancet 1998 there, all wavy. Why couldn't they just lie it flat on the photocopier when they were scanning it? Anyway, luckily this stuff was well received and got quite a few prizes along the way, which was delightful. But it wasn't, again, all about the work, because the music also had to happen at the same time. And poor Ian was dragged to see my band, a band I was part of, the Lazy Days. One of our singer is in the audience, Andy Richards. And we played at the Rock Garden in Covent Garden, the Underworld in Camden Town, had a great time. And it is actually all on Spotify, if you can bear the thought of listening to our sort of pretty good imitation Britpop, is perhaps how I would have called it. And as well, during the PhD, something far more momentous happened, which is that Sue and I got married, and it was an absolutely fantastic day. Ian and Usha were there also. So then, moving on from the research, it was time to get back into clinical training, and again, worked for some real luminaries in the field. And then I got the call from Ian in 2004 saying, would I like to come and be a lecturer at UCL? And of course, I jumped at the opportunity. And while I was there in that first year, Ian and I persuaded the Royal College to allow us to create what I believe was the first academic gynae-oncology training program in the UK. And so I did a 3-year program rather than the usual 2-year surgical training program. And while all this was going on, Bruno came along and Arnie came along. And they were happy times, but in all honesty, they've turned out the way they have, thanks to Sue. Sue's been an absolutely extraordinary mother, and the life I've led, I've not necessarily been the most present dad, as you can imagine. But while she's done all of this, she's also had a career of her own, and she's actually the director of neuroanesthesia at Great Ormond Street. And the stuff she does is seriously hardcore. I wouldn't touch this kind of risk level with a barge pole. So I don't know how she does it. It's extraordinary. So the time at UCL with my gynaecology training also involved being on the senior registrar rota. And again, if you look at the names of the people that were on this rota, it's no wonder I had an absolutely fantastic time here. The people in light blue are all now consultants here. Those in the darker blue are consultants elsewhere, but pretty much all of them at major UK teaching hospitals. The other reason it was great working here was my surgical mentors, Tim Mould and Adeola Leighton. Sadly, neither of them working here anymore, both now retired from here, but just the most extraordinary mentors, not just in terms of the surgery they taught me, but also in their attitude to patient care, which was absolutely first rate and really inspiring. Now, during this time, I also met Martin, who'd come across to work on the research side with Ian, but also to train as a gynaecologist. He was actually a breast surgeon in his home country of Austria, but decided he wanted to do gynaecology. And Martin is another really good example of how I have basically attached myself to another far brighter individual and got a lot of benefit out of it. Because Martin is a real planet brain and he is making a real difference. And not only does he publish in Nature Medicine, but he gets them to do the front cover of that issue about his research. And we've got Yona and Ali from his lab here in the audience and here on screen. And Martin has developed this new endometrial cancer test, the WIDQ EC test, which is now about to go through, I hope I'm allowed to say, about to go through some NHS testing, but it's looking extremely promising to enter mainstream clinical practice. During this time at UCL as a suspect trainee, I was encouraged by Adeola to apply for an Ethicon traveling fellowship, and I spent 2 amazing weeks in Brazil working with this man, Artelicio. And for those of you that work in craft specialties who have not yet been to a developing country, if you're allowed to call Brazil a developing country, you really need to do it, because you will never take NHS facilities for granted once you've worked in a place where the surgical gloves and swabs are sterilized between every operation, and your suture material is literally a reel of sewing cotton put through an autoclave and used with a reusable Mayo needle in order to do your surgery. So this is why I get angry when people use disposable equipment and someone opens the wrong bit of kit in theatre, because we don't know how lucky we are to have this stuff in the NHS. So finally, in 2015, I made it back here and was appointed as a gynecologist. And I've got a big grin on my face because we know this place is good. And I know that league tables, there are lots of arguments about them. Are they really justifiable? What metrics do they use? But if you dial up Obs and Gynae on the Time magazine, sorry, Newsweek magazine's World's Best Specialist Hospitals, we're actually apparently 3rd on the planet, which I think we should all be extremely proud of. So what do I get up to clinically here? Well, we've got our colposcopy service. We're extremely busy, and I'm particularly proud of our very high cure rate for the women with pre-cancer that we treat. And you can see some of our big team here, and we've got multiple consultant colleagues from gynaecology who are all an amazing bunch and who make it so easy when we do find one of our patients sadly has got a cancer to take forward their treatment. I've put Joyce in bold there because she really runs the shop and gives me a little bit of headspace to do all the other things I need to do. She also does an absolutely amazing lemon drizzle cake. Victoria, one of our ex-fellows, is actually working with us now as a regular colposcopist, despite being a trainee in pathology, which I think is pretty unique and impressive. And there's other people here I'm sure I will have forgotten to include on the list, but we're a big team because we've got a lot of patients to see, and I think we do it pretty well. The other kind of feather in my hat is the Familial Gynaecological Cancer Service here. This is mainly about counselling the women with germline alterations. And big thanks to Melanie and the Menopause team for the huge support that our patients need, and to Jenny Van Heerden, our clinical psychologist, because lots of these women, not surprisingly, have real issues around decision making about when they want to have their fallopian tubes and ovaries, and sometimes uteruses removed as well. In terms of the surgery itself, we're doing around 50 to 100 cases a year. I'd like to thank Arvin and the robotic team, and Guljan from the Washington, who help us with our very big waiting list, which is an ongoing issue. But not forgetting Davor and all of the Clinic 3 consultants who offer us an incredible service with urgent scans when we're worried our patients have developed cancer. We also, and this is not something that happens much around the UK, are offering surveillance for women with Lynch syndrome. And big thanks to Ertan Saradogan and now more recently Shirin Kanjani for the outpatient hysteroscopy service. We've been joined recently in our service by Costas from the Gynae-Onc team, and we've currently got Dimana as our fellow, and Sophia is our very able administrator. Now, if you work in oncology, you absolutely have to have good relationships with pathologists. They are totally integral to what you do. And I've had the privilege to work with really genuinely world-class pathologists. When I was at Barts, I worked with Navina, Asma, and Debbie. I've got a photo of Navina here because not only was she a world-class pathologist, but she was a really wonderful human being. Everyone that knew her knew that. And Navina was taken from us very recently, far too soon, and has been a huge blow to the gynae-oncology community internationally. At UCLH, I work mainly with Rupali and Tanya Allen, two absolutely outstanding pathologists, but they're really part of a bigger team, and the other pathologists also look after the diagnoses in our patients superbly. And no longer working here, but a fine cytopathologist, John McGloin, I can thank for introducing me to Ronnie Scott's, which I'm now a member of, and I take many of my friends there to see concerts. So big thanks to John for having introduced me to Ronnie's. So back to a little bit of research. So when I was at Barts, we noticed that there was a big increase in the referrals coming through because of this sad situation, which I'm sure many of you remember. Reality TV star Jade Goody got diagnosed with a cervical cancer. She had an abnormal smear. I believe she was in the Big Brother house at the time that the news was broken to her that she needed to actually go and get checked out. And sadly, she already had a cancer at that point, from which she subsequently died. And we thought we ought to at least look into whether this was a real phenomenon or not. And it turned out it was. That not only had referrals to colposcopy massively increased, and I should add that this work was done primarily by two medical students, Ben and Jen, who you can see in the middle there. Not only did the number of referrals increase rapidly, but the number of women diagnosed with high-grade precancers was also increased. Now, if you're a bit cynical, you'd say, well, didn't this diagnosis of Jade just pull forward all of these diagnoses, because maybe those women would have turned up for their colposcopies eventually? That may be true, but by bringing forward their diagnosis, for some of them would have diagnosed them at the point that they had precancers rather than cancers. And therefore, Jade undoubtedly prevented many women from getting cancer. Another little bit of colposcopy work that we did more recently was one of our MSc students, Kevin, I hope is joining us live from Indonesia. Hi, Kevin, if you're there. Looked at our experience of conservative management of patients with CIN2. So as Anna alluded to, if you treat people's cervixes, unfortunately, you shorten their cervix. That reduces the length of the mucus plug, increases the risk of ascending infection, and that can cause premature labor and second trimester miscarriages, which is huge morbidity for women, their families, and their babies. So if you can avoid treating, it's a really good thing. And what we found was that our policy of not treating appears to be safe, because we have very high rates of regression of women with CIN2. In 2015, Mayura Nathan, you see in the middle of this slide, gave me a call and said, we really need someone else to come and learn high resolution anoscopy because there aren't enough people doing it. And he'd set up this service at the Homerton. So it turns out, for those of you that don't know, that human papillomavirus not only causes nearly all cervical cancers, it also causes nearly all anal cancers. And sadly, anal cancers are massively on the increase. probably because of the higher rates of HPV since the introduction of the combined oral contraceptive pill in the 1960s. For those of you that are wondering, women who have HPV in their anal canal, it's nothing whatsoever to do with sexual practice. This is a virus that's highly trophic for the anal mucosa. And there is a theory that it's in cultures that you are taught to wipe front to back after going to the loo, rather than in dabbing, which some other countries are taught to dab when they pee. This results in transfer of the virus from the front to the back, and hence into the anal canal, where it causes all sorts of problems. And anal cancer is now predicted to be the most rapidly increasing cancer in women, and it's estimated that rates will double by 2030. So there's a huge team there. I'm really a very minor cog in that wheel now. I just do a clinic there once a week on a Friday morning. But it's really important and fun to be involved in what's really now seen as an internationally recognized centre for this sort of really rapidly evolving branch of cancer prevention. And I've been privileged to be a co-author on a number of papers out of that team, which are essentially validating the approach, which is seek and destroy. It is identify women who do have precancerous changes, and men as well, I should say, who have precancerous changes in the anal canal, and treating it with ablation using a laser or diaphragm. So, brief pause before we move on to what's been one of the real passions of my career, which is the title of this talk, An Unwelcome Inheritance. So those of us working in gynaecology have known for a very long time about the autosomal inherited genes BRCA1 and BRCA2, but the world at large woke up to it in 2013 when Angelina Jolie went public with her op-ed in Time magazine, describing her experience of being diagnosed and undergoing bilateral risk-reducing mastectomies to prevent her from getting breast cancer. She's also had her tubes and ovaries now. So, because not everyone in the room is familiar, I will give you sort of very brief background as to what the issues are here. So you have massively high risks of ovarian as well as breast cancer if you have one of these genes. And the risk can be as high as 27% by the age of 50 if you've got BRCA1. Fortunately, not quite as high risk if you've got BRCA2. But it's that key point of being the risks occurring in premenopausal years that makes this such a devastating diagnosis for so many women. Typically, if you're not found out to be a carrier and do something about it, you're going to present eventually with a very advanced staged ovarian cancer if you are unlucky enough to get it. And those of us that work in the field know that this is a really morbid situation to have to treat. And the recent National Ovarian Cancer Audit in the UK found that over 40% of women with ovarian cancer are actually diagnosed via emergency presentation, which is typically in bowel obstruction with an absolutely dreadful experience and a dreadful cancer journey, and sadly still not a great prognosis. So the only way you can really reliably prevent ovarian cancer is to, as I mentioned before, have the organs at risk removed. But that means if you're premenopausal, losing your hormones, losing your fertility, and needing long-term HRT. So not surprisingly, many women delay their surgery until they've completed their families or until they've reached natural menopause. Trouble is, if you delay, you risk getting the cancer. So what could you possibly do in the meantime? Well, we'd hoped to be able to offer surveillance as a safe alternative. It turns out that's not the case, but I'm going to take you through the evidence and where we might actually be able to be now in 2025. Now, there is also, some of you may have heard the option now of having your fallopian tubes removed first and having your ovaries removed afterwards once you've become menopausal, because the vast majority of these ovarian cancers start at the end of the fallopian tubes. But this is part of an ongoing clinical trial to which I'm glad to say UCLH is recruiting patients. And we don't yet know the safety of this approach. It may not be safe for everybody. And we reckon it's going to be at least 5 years before Ranjit and his team at QMUL have the first sense from the data as to whether it really is as protective as we think it's going to be. So, whilst the ideal goal of high-risk population cancer surveillance is to reduce the mortality from that cancer, we know that surveillance, at least with current techniques, can't actually prevent it. And currently, no test has been shown to detect the majority of ovarian cancer prior to metastasis. So you can't guarantee cure with surveillance. And for that reason, there's no doubt in anyone's mind that confirmed high-risk women really need to be offered the risk-reducing surgery. And there is data now that's already over 15 years old, showing us that this does save women's lives. So in 2025, I think the realistic goal of high-risk population ovarian cancer surveillance is to limit the morbidity of any cancer that is detected before the woman has risk-reducing surgery. It can only be used in those who are not ready or willing to have the surgery, and it must not be used as a reason to indefinitely delay their surgery. But maybe it brings them a little bit of breathing space to think about things and hopefully go for the surgery. So does it achieve this goal? Well, this journey started in 2002 before Ian asked me to join, but I came onto this program in 2004. And this was annual surveillance for women at high risk of ovarian cancer using a simple blood test and an ultrasound scan just once a year, all managed locally. And that meant we couldn't control the situation particularly tightly, unfortunately. There are a lot of cancers detected, but we also had 2 cancers that occurred with symptoms between the annual screens. So that was disappointing. We had pretty good surveillance performance characteristics for those of you that understand these kinds of stats. It basically means it wasn't bad level of accuracy of the tests. And we also found that there did appear to be some effect on downstaging of cancers, in that those that had a screen in the last year appeared to be less likely to have very advanced cancers than those that have not. And also there appeared to be a correlation there with the amount of surgery that they would require to get rid of their cancers, which sort of made sense if we're diagnosing the cancers earlier. So we concluded that we had pretty good performance characteristics, but some of the delays that occurred because we weren't controlling the system tightly could have resulted in some of the later stage diagnosis. And we know we weren't doing well enough because patients were still presenting with cancers between their annual screens. But fortunately, Steve Skates, a biostatistician from Harvard, and Ian had come up with the idea of an algorithm that looked at the rate of change of that blood test CA125, and that was already happening in the massive UKFOCSS randomized controlled trial that Ian and Usha were running in the general population. And essentially, all you need to know about ROCA is it's about pattern recognition. So these are individual patients plotted over around 3 years, and they've all got levels of the CA125 in the blood, which is above 30, which was typically the cutoff for what was considered normal and abnormal. They've all got high levels on this logarithmic scale, but they all stay the same or fall over time. But all of these women who've got ovarian cancer have got rapidly, exponentially, in fact, rising levels, or nearly all of them have got exponentially rising levels of CA125. So essentially what the test does is it's a computerized algorithm that looks at patterns and says, is this woman's pattern more closely aligned to the first kind of patterns, so stable or falling levels, or rising patterns? And it gives you a numerical risk, which is great, because if you've got a simple number to deal with, you can use that to triage patients into different categories of risk and act accordingly. And so what Steve did is he adapted the algorithm for use in the high-risk population, which takes into account women's ages, their menopausal status. We've got to remember that fluctuating levels are found in premenopausal women more than in postmenopausal women, because CA125 goes up with menstruation and with benign conditions such as endometriosis and fibroids. And so he adapted the ROCA algorithm so it could be used in the high-risk population. So that's what we started doing in 2007. And we also decided we really need to do it every 4 months, which is very intensive testing, but we didn't want to get any interval cancers coming through. And the women were prepared to do it because they were worried about their risk. And essentially what we have here is a traffic light system that was used. So if your risk was deemed to be low by the algorithm in green, you just carried on with the 4 monthly testing. If it was yellow or amber, you ended up with more intensive testing, including an ultrasound scan. And if you hit the NICE threshold for referral straight away, 1 in 33, that's what you did, you referred. And we had, again, very good performance characteristics. And this is just looking at the BRCA carriers specifically, because eventually it looks like this is the group we're really going to be doing this for. And what you'll notice there is the positive predictive value, 42%. That means you're operating on roughly 2 women for every case of cancer detected, which I think is pretty impressive. And honestly, I don't mind about the false positive cases because these are women that should be having the surgery anyway. And so I don't actually personally view it as the end of the world if you get a false positive in this setting. And we did find that this earlier diagnosis that we achieved through the surveillance, first of all, we found that we got earlier diagnosis, first of all. So again, statistically different rates of the most advanced disease, but that did correlate into having less remaining cancer after primary surgery, less need for chemotherapy beforehand to shrink tumours down so that they were operable in the first place. And also, and I think this is really important for the patients themselves, they needed less complex surgery. Many of them required just removal of their womb, tubes and ovaries and the omentum, which is a bit of fat that hangs down from the bowel and doesn't serve any real useful purpose, rather than needing the massive operations that my incredibly talented gynaecological surgery colleagues are carrying out at UCLH and other centres around the UK. So there appears to be a clinical benefit to undergoing the surveillance if you're not ready to have the risk-reducing surgery and you're unlucky enough to get a cancer in the meantime. So just a few shout outs here to Ian and Usha, obviously. Ranjit was the clinical fellow on UKFOCSS after I went into consultant jobs and kept things going nicely. It would have been completely impossible to run without Lindsay Fraser, who was the most extraordinary project manager, Andy Ryan and Rob Liston, who I couldn't find a photo of anywhere on the internet. He knows how to hide. Were the incredible database guys on this. Sue came on with UKFOCSS and has helped me massively with ALDO, which I'll come on to in a minute. And then Alex wasn't actually part of any of those trials, but was such an integral part of the whole unit and has become such a great friend and is now actually head of the Department of Women's Cancer here at UCL that I really couldn't not have a photo of her there. So with all of that encouraging preliminary research work, we persuaded people that we should take this forward into the NHS. We won a Cancer Vanguard Industry Early Diagnosis Challenge in collaboration with Arcodia, the company that at the time held the license to the Roca test at UCL spin-out company. And we launched this program. And we decided we'd do this just for BRCA carriers because it became apparent from the UKFOCSS trials that really the vast majority of the cancers were occurring in that group, because although the other groups had an increased risk, it just wasn't as high. So this was the group we really wanted to focus on. And we essentially did very similar stuff to what we'd done in UKFOCSS. And we invited the women via these groups. And I'm very happy to say that all of the major players in the patient public involvement arena got on board with publicising the study. So we managed to get people on board. And I won't dwell on this in any great detail, other than to say that I think it's worth highlighting that only 3% of the women on the programme actually needed referral for assessment, and only 1% underwent surgery. So it's not like this is going to massively overburden gynaecological services if we do take this forward. We found a bunch of cancers again. We didn't get any interval cancers again, as we hadn't done on UKFOCSS phase 2, and about half of them were diagnosed before the most advanced stages. I still believe that last case should have been completely cytoreduced. They would have been for sure if they'd been operated on in this centre, but they were operated on another centre and someone left some disease in the pouch of Douglas, which there's no way that would have happened if she'd been operated on here. So we should have had a 100% hit rate on that. So what we really found was that we'd replicated a research trial in an NHS real-world setting. And anyone that works in research and clinical research will tell you that is a very hard thing to do. And I think it's a huge tribute to all of the centres that took part in this. And also, on a day-to-day basis, it only took a couple of hours of my week, every week, to keep an eye on things while Sue Philpott worked full-time on it. So you can manage a programme like this with very little person power, which makes it pretty good from the point of view of NHS resources. So now, this slide actually sums up over 20 years worth of work. And this is all of the 3 high-risk trials using the Roca test in patients at increased risk of ovarian cancer, looking just at the BRCA carriers in those populations. And this is UKFOCSS phase 2, this is ALDO, and also Steve Skates's parallel trial in the US. And if you concentrate on the columns either side of the middle, essentially what you're finding is that you're halving the rate of patients who are on surveillance with the most, they have half the rate of being diagnosed with the most advanced cancers. So in conclusion, it's feasible and cost effective to do this in a real world setting. It does downstage ovarian cancer with likely clinical benefit. And we also found, thanks to collaborating with Annie McGuire and Maria Riker at the London School of Economics, that this is probably cost saving to introduce because it is so fabulously expensive to treat advanced ovarian cancer that if you can downstage it, then you can at least save quite a lot of money for the NHS. But at the end of the day, it goes without saying that risk-reducing surgery has to remain the recommended management for this patient group. If you delay indefinitely, thereby danger lies. But ROCA-based surveillance should be considered, we believe, in those declining surgery, but clearly careful ongoing counselling is essential. And those bits in italic are almost word for word what has now got into the NHS NICE guidance on managing patients with familial ovarian cancer. And I was privileged to be on the guidelines committee for this. For conflict of interest reasons, I wasn't allowed to talk at the meetings about surveillance, but I did run the work stream that looked at safe implementation of risk-reducing surgery. And we also had Melanie Davis from UCLH advising on the menopause side of things. So we had exceptional UCL representation on this guidance that came out last year. And I know it's been controversial, this guidance, mainly because it has recommended a lower threshold for offering gene testing. But those gene testing thresholds are set by the economic analysis, and the uproar, if you like, quite understandably has come from the clinical genetics community, who are going to be totally overwhelmed if this number of men and women get tested. But those of us on the committee felt that it was really important to not waste this opportunity. And if we had evidence that this could be a life-saving intervention, essentially, by doing gene testing, we had to set the bar to what was economically made sense for the NHS. And we had to say, well, this is the bar, and it's now up to the commissioners to fund it. So I'm sorry if it causes a lot of antagonism, but I really think we need, as a National Health Service, to roll out more gene testing because it really does save lives. So we're taking this forward slowly, but hopefully surely, with a business case to start rolling it out locally. That hasn't yet been signed off. We hope to hear about that in the next few months. And we've also just submitted an application to specialist commissioning to get this in, hopefully sorted out for a national surveillance program. But again, I can't emphasize enough, it needs to be a package of care as endorsed by the NICE guidance, with an annual review with the women once a year, so we can rediscuss their risks and see if they're not actually ready to have surgery as yet. So if Stuart's in the audience, I hope you are, please can we have a CNS, because we're really going to need one. So moving on, I wanted to talk briefly about sort of the parallel side benefits of having been involved in this research. I'd like to think, friends with the great and the good of the UK clinical cancer genetics community. And I'd like to give a big shout out actually to Lucy Side. Not that I'm any more friendly with her than any of the other guys and girls on this list, but because it was Lucy that invited me to join the steering committee of the UK Cancer Genetics Group back in, I think it was 2009. And it's how I got to meet all of these people. And they're an amazing bunch. And these are the people really responsible for identifying risk in the general population, counselling them, and putting them in touch with people like me to make sure that they can get access to their cancer prevention strategies. And I now have the pleasure of chairing the London Cancer Gynae Risk Reducing MDT, and we've got representation for all of the major genetic centres there. Some of you are in the audience, some of you are dialing in online, I believe. And it's a really stimulating monthly meeting that we have. I can't tell you how much I get out of them and how much I enjoy going into the annual UK Cancer Genetics Group's meetings. Now, as well as meeting a lot of great people, UKFOCSS and the research that went with it generated an amazing serum bank, which Usha Menon was the most extraordinary custodian of. And Martin, being the planet brain that he is, had a theory about hormones and BRCA carriers. And he asked me, do you have endometrial thickness measurements? And I said, yeah. And he said, do you have the blood samples? And I said, yeah. And so we've initially looked at the endometrial thickness of BRCA carriers compared to age-matched controls who didn't have BRCA1 and BRCA2. And we found, lo and behold, if you looked at the days of the menstrual cycle matching as well, that they had thicker endometriums. And that did mean there could be a hormonal difference. And what we found was that there were higher levels of estrogens and progestrogens in BRCA carriers compared to non-BRCA carrier controls. And lo and behold, this might be one of the mechanisms by which BRCA carriers have such a high risk of breast cancer. And something else that I'm really proud of, even though I was a really minor cog in this wheel, was it partly came out of one of those round the coffee table conversations you have with scientists in a place like this. So I was talking to Susan Ramus and Simon Gaither, very eminent genetic researchers, now no longer sadly at UCL, but working in Australia and America. I said to them, all these new genes that are coming through, don't you think the UKFOCSS population is going to be the ideal population to test the theory out in? Because we know that only around 15% of the UKFOCSS population have got BRCA1 and BRCA2, but they all come from families with more ovarian cancers. So surely we're going to have some of these other genes there if indeed these genes that are thought to cause ovarian cancer do. And it turns out that we were right. UKFOCSS formed part of the validation cohort used in these two studies. And these two studies have been the main drivers really for the introduction of these genes onto the ovarian cancer gene panels that are now available through the NHS test directory for patients with ovarian cancer and patients from family histories with ovarian cancer and breast cancer and so forth. I've also been involved in some other guideline development, notably the RCOG Green Top in managing endometrial hyperplasia. And hats off to one of our consultant colleagues, Jess Farron, who's just developed a really good patient-facing explanation as to how their hyperplasia will be managed. I was also fortunate enough to be invited to the Manchester Consensus Conference on Managing Lynch syndrome, and also these more recently discovered moderate penetrant genes. I've been involved in setting the guidance for how they should be managed, ideally from a gynecological perspective. I've also had a fruitful collaboration with industry through Julie Barnes and Abcodia, which has now been bought by Genencode, because as I've already mentioned, these guys hold the license to the ROCA test. And working with Julie has been really, really good fun. We're still working together and long may it continue. Now, another thing that's been an absolute joy to be part of has been charities, in particular the Eve Appeal. And I know that we've got Athena and Vass in the audience. We've had an amazing chairperson of the board, previously Melanie Richards, and we've now got an equally dynamic chair in Tamara Box. But Athena has been an absolute force of energy, force of nature in really getting this charity to the incredible state it's in now, as being by far and away, I think, the most important gynae cancer charity in the UK. And I'm still proud to be a board member with them. And when you align yourself with a charity, you get to do lots of other fun things, like get invited to a panel discussion at the RCOG. And you can see second from the end there is the late great Dame Deborah James, otherwise known as Bowel Babe, who did so much for increasing bowel cancer awareness. You also get invited to things like the all-party parliamentary group on ovarian cancer at the House of Commons, and it was great to be able to speak at that. I've also enjoyed introducing new surgical procedures. I hasten to add, none of these invented by me, but the sentinel lymph node procedure with vulval cancer, I was the first person to do that at BRCA. I came over to UCLH before I was back here, and Martin taught me how to do it. And also, as mentioned before, we're taking part in the trial looking at risk-reducing self-injecting and delayed oophorectomy. So we're now offering that for our women here. And also I've started, well, many years ago now, I introduced needle excision of the transformation zone in the hope of giving Anna David less work, because this way you can do a much more precise excision of a precancer on the cervix, reduce the amount of damage to the cervix and reduce the risk of preterm labour, we hope, as a result of that. And this is just the day surgery crew who are often the ones who help me out with doing this. And big shout out in particular to Liz on the end in the red top, because she is an amazing scrub nurse and runs the team brilliantly. I've also had some forays into combining surgical procedures, the surgical buy one, get one free option, basically. I first did this back in 2013 at Barts when we had a patient I was doing a hysterectomy for endometrial cancer on, and she happened to have a coexistent renal tract cancer. Now, of course, we would know that this woman probably had Lynch syndrome because it causes an increase in both of those cancer risks. But fools that we were back then, we didn't know it. Anyway, we got a urologist to come and help, and he did the nephrectomy. More recently, when I started at UCL, we had a woman with BRCA who also had gallstones. So why not do both at once? It seemed to make sense. And most recently, really, I was the minimum bit of this because the needle excision doesn't take very long, but Ertan did an absolutely amazing laparoscopic cerclage. But this was great prophylaxis against preterm birth, because this was the woman's third excision of part of her cervix. So it was really inevitable she was going to have premature labour if I was to go and remove a bit more of it. So by putting this suture in, hopefully we'll end up with a live birth for this patient eventually. But this surgical bog-off thing then has developed. And I can't believe that after all of these years I've spent doing these massive clinical trials, the thing that everyone seems to have heard about is 4 patients. And maybe it's because it was a good news story, I guess, and the media really took it up. So with the help of Pat and Joseph from our obstetric team, and then written up by Victoria, one of our ex-fellows, we published this case series. This was again down to a patient coming to me. So she was the planet brain this time, not another doctor or researcher. And she said, I'm the BRCA carrier. I've completed my family after I've had this baby. Can't you just, as I know I'm going for a section because I've had one before, can't you just take my tubes and ovaries out at the same time? We discussed it as an MDT and we said, yeah, okay, I'll do this for you. And there have been 3 more since since this case series of 4, there have been at least 3 others. But I got to go and meet Dan Walker on Channel 5 News, and it made a few headlines, which was really lovely. Other things I've really enjoyed doing, being part of the Pan London Colposcopy group. And for those of you who don't know, Deirdre, who's been the real driving force behind that, and Teresa, they're both North London colposcopy leads for their respective units, and they're both current or ex-presidents of the British Society for Colposcopy and Cervical Pathology. So to work with people of this caliber in your day-to-day life is fantastic. And we've presented posters and talks at the annual scientific meeting and won lots of prizes doing that. So well done to Halima and Victoria, our fellows, and we've had some other winners earlier before. Nearing the end now, guys, because I know you want your drinks. We've got, this is a really important new initiative in the last couple of years. Kevin Monaghan down the bottom and his nurse Laura are the national leads for Lynch syndrome UK-wide. He's a gastroenterologist at St Mark's, not far from here. And he has been trying to get all of the places around the UK to make sure that they are managing these patients properly, because he knows there are lots of preventable cancers that we're not managing to prevent because men and women are slipping through the net. I should say Lynch syndrome increases the risk of bowel cancer predominantly, which is why we've got gastroenterologists involved. And because it affects men as well as women, because men have bowels as well as women. The person who does the most work on this is actually Rosa, our gastroenterologist, because she does a huge amount of colonoscopies to prevent bowel cancer in these patients. But we've also more recently had Helen Francis, our wonderful clinical specialist, and Vimo, our urologist, because I've already alluded to, we've got an increased risk of renal tract cancers in these patients. And we've got James and Simon driving this all forward. And we're trying to get funding to continue to do it at the moment. Please, guys, please do fund it. Because Kevin, who sees what goes on around the whole of the UK, says UCLH is currently the national lead on this as far as getting it to the most advanced stage is concerned. So we've got to carry on doing the research in order to get things better for everyone. This is my penultimate slide, you'll be pleased to hear. So Mali's in the audience, our PhD student, and he's done great work putting together our 17 years of experience, and we have detected lots of early stage endometrial cancers, and even more encouragingly, pre-cancers, which means that although the women still need a hysterectomy, they're avoiding the psychological burden of a diagnosis of cancer, and they're avoiding the possibility of needing radiotherapy, which increases morbidity as a result of their surveillance. We're also running, and I'm really excited about this because this is something I wanted to start doing many years ago, but at the time, the menopause team weren't keen on the idea. But now Zach, the menopause team's research lecturer actually, has started offering women with BRCA mutations the opportunity to have a temporary chemically induced menopause with add-back hormone replacement therapy to try and mimic how they might feel after they've had their ovaries removed premenopausally. And hopefully that will help them make up their mind that actually maybe life isn't so bad on HRT, and maybe they're now prepared to go for the surgery, hopefully soon enough to avoid the diagnosis of ovarian cancer. Felipe is our new gynaecology research consultant here, and I'm hoping to have a fruitful collaboration with him on his UK grants. I'm also hoping to set up this project looking at follow-up in women with early stage cervical cancer and glandular pre-cancer with Mateshka and Deirdre. The NHS has the most unbelievable resource in the NHS screening program, and the fact that the data is mandated and collected nationally. We're just having a bit of trouble getting our hands on the data at the moment, but if we can get our hands on the data, we know we can improve the follow-up schedules for these patients and make them far more efficient, and hopefully enable us to discharge patients from ongoing follow-up and the anxiety that causes much sooner. And then just in the last week, we've had meetings with the great and the good of the Lynch syndrome world in the UK, looking to introduce Martin's amazing new endometrial cancer test as part of a project nationally looking for screening for Lynch syndrome. So I think the future is bright. So cheers, everybody. Neil, the bass player in our band, sadly can't be here today because he's now a retired GP and he gets to play the bass in semi-professional bands, and that's what he's doing tonight. And I couldn't possibly have a talk without showing our beloved dog, Indy, who couldn't be here either. I think that's it, and I'm just going to quickly grab here because Sarah has done such a great job organising this. So thank you all. Thank you very, very much. 1 hour pretty much on the dot. Not bad. Okay, thank you all very much.
Well, Professor Adam Rosenthal, that was a wonderful exploration of your work. It was a tour de force and a brilliant inaugural lecture. Thank you so much. My name's Ian Jacobs. You saw my picture a few times there, and it's for me, it's a privilege and a joy to be here and to have heard Adam's lecture. You're surrounded tonight by people, your colleagues and your family who are proud of you. And I suspect that over the 40 years of this wonderful career, there have been few times that you've brought all those people together. And probably your family haven't seen you perform that often. You probably brought those people together at a performance of the Lazy Days. Not all that memorable to most of us. And definitely you brought everyone together at your wedding. But probably since then, I don't know how many times that everyone's been brought together. And it's really, these occasions are particularly lovely because you bring together people from all different parts of your career and your personal life. And of course, Adam, you are an exemplar of someone who has worked really hard, but has also had a well-balanced life. And I couldn't let the occasion go by without just saying again how great it is to have your family here. Sue, your wife, Bruno and Arnie. Arnie's in the front row, Bruno's hiding at the back. And we've got Daniel, your brother, and most important, Anne, your mum. It's wonderful to have you here. So if some of you have been listening online or here, who aspire to be a professor, what can you take away from what Adam's done? I think that there are two very different components that make a really great clinical academic. And Adam exemplifies both of them. The first is the quality of what you do is really, really high in everything you do. So it's the technical quality. And Adam's done that in so many areas. He is a wonderful clinician. I can vouch for that. I've seen patients benefit from his clinical care, both medical and surgical. You heard, you need to hear nothing more, that he's a stellar researcher, and his contribution in research, in prevention and early detection of cervical and ovarian cancer really has had an impact on the lives of women and their families. He didn't say much about education, but he's also a great teacher. And I've seen medical students and junior researchers and clinicians in training all benefit from the way that Adam teaches. His communication skills, you saw them on display tonight. He has superb communication skills, not only with people in the profession, but also lay people. And of course, his contribution as a trustee of that wonderful charity, the EVA Field. We heard a little bit about that. So Adam is technically at the absolute top of the game. But there's another thing that you need to do to be a truly great clinical academic and to become a professor, and that is the way you behave to other people, to patients, to your colleagues, in partnership and in collaboration. I think that Adam is at the top of the game in that respect as well. And you heard in his talk, how many pictures do you think he showed of other people and gave credit to them? I counted 60 and then I stopped counting. And I think that approach is exceptional. So his approach to his colleagues, whether clinical or research, has been absolutely exceptional. But that was also the case, and I saw it many times with his patients and with his partnerships and collaborations with people he didn't know well. So Adam is, I'd say, characterized by nurturing lifelong friendships and partnerships and collaborations, really caring about people, always being respectful, even when he disagrees with people, and always being prepared to hear other people's points of view. So I think the big lesson that I take away from Adam's career so far, it's not over yet, and there's great stuff to come. I think it's that combination of technically being a really great clinician, researcher, educator, communicator, and charity worker, and combining that with just being a really wonderful person who's respectful, kind, thoughtful, and cares about other people. So I want to give you one last chance to congratulate Adam. Adam, would you please come up, stand up the front. Round of applause. And I think that drinks